Well, that was a really pleasant calming of the audience. I didn't do anything. I just stood up here and y'all were just enraptured already. Thank you for being here for our annual Homer G. Phillips Lecture Series. This is, what year are we? I have to go back and look and see. 27th. Oh my goodness, 27 years of really honoring the legacy of the hospital, the people who were there, who traversed the halls and created history. The physicians, the nurses, the allied staff, the pharmacists. It's quite a story which really still resonates with all of those who want to know about the history of public health, and particularly the history of public health in African American institutions in this country. That history, a lot of the history was formed here in St. Louis at the Homer G. Phillips Hospital. And so it's always a pleasure to memorialize all the people who walked in that hospital and helped draft that history, which really emboldens all of us to promote public health and all this and all the efforts that we need to do, public advocacy, practice, research, teaching. So those are the things that we're honoring tonight. 27 years, and I dare say that I know a number of you have been here for 27 years. And I'm not picking on anyone, but the people who I love the most are the nurses, the Homer G. Phillips Nurses Auxiliary. They have kept the legend. They have carried the torch, and they've done so for many years. They were the ones who contacted me and said, "We'll keep it going, keep it going." And so we have to recognize them, their efforts. They were there behind the scenes. So those nurses who were here for all 27 years, anyone else who's been here, can you please stand and let us just applaud you? Now, the nurses have been involved, they will continue to be involved in advocating for social justice, health equity, and they're involved in one current effort. We won't go into details, but they're endeavoring to really ensure that the name Homer G. Phillips remains among the pantheon of individuals and hospitals that really warrants inclusion in history. And so they're not anxious to see that name become denigrated in any manner. And so I know they're involved in an effort, and I'm going to give them just a second to talk about that effort, if anyone wants to share that.
Thank you. I'm from the class of 1963, and we just celebrated our 60th year. And also with our alumni, we had our 101st celebration. And with us today, we do have one of our favorite instructors. Oops, should I say that? She was our psych instructor as well as a graduate of Homer Phillips. So she's the class of 1956. So I do have some... So we do have some information letters here. Not only talks about our history, but it talks about the infringement, the copyright infringement lawsuit that we're working with right now. So if any of you would like information on that, we do have the flyers for that. So we appreciate you, each of you, for supporting us, because it's been a long, hard fight. Not just from 1922, when we had our first graduates of 5 female nurses, and then our last class of 1968, we have a few here. And then the last class, I think they had about 34. So from 1922 to 1968, we had 1,037 graduates. So even when they closed Homer Phillips and St. Louis City Hospital, those 2 nursing schools, they combined them into the St. Louis Municipal Schools. So in the few years they were open, they had 418 graduates. So we just thank you for your support. Enjoy your evening. Take care.
Thank you so much. It is a venerable history. Between the years of 1937 and 1979, 1 out of 3 African American physicians in this country were trained at Honoree Phillips Hospital. Did you hear me? 1 out of 3. It's the largest training program for African American physicians in the country. I've done an experiment as I travel. If I encounter a physician who's over 65 years old, I walk up and I'll ask, did you train at Honoree Phillips Hospital? I figure I have a 30% chance of finding the right person. And invariably, they'll say, yes, I trained there, or no, I didn't, but I know someone who did. I still do that across the country. It's just a remarkable impact. And it just really warrants that we honor all those people who were part of that history. And tonight, we're going to do that consonant, consonant with what we've done in the past, honoring a major leader in this community and in the history of Honoree Phillips Hospital, and that leader is none other than Dr. Nathaniel Murdock, Jr. We're going to hear a lot about Dr. Murdock in a few minutes, but before we do that, I want to introduce you to some of our institutional leaders who have also really been supportive of this effort, supportive of our commitment to the community, recognizing, as the Chancellor always states, that we should be Washington University for St. Louis, not just Washington University in St. Louis. We need more people here. We need more seats filled. We need all of St. Louis to know what has been done, what has transpired in the past, and how we, again, will continue to memorialize that history. And so it's my pleasure first to introduce Dr. Eva Agard, who will bring us a welcome. Dr. Agard is Vice Chancellor for Medical Education and the Carol B. and Jerome T. Loeb Professor of Medical Education and Senior Associate Dean for Education. In this role, she provides oversight and direction for educational programs for the School of Medicine, including undergraduate, graduate, continuing medical education, as well as allied health and other degree programs. She led the development of our new Gateway curriculum, a remarkable and really difficult endeavor to take a curriculum over the past decades and really transform that, moving our students to learn in more active manners through team teaching, flipped classrooms, and other ways, and most important, and more just as importantly, having our students engage in a longitudinal manner in community service, community engagement, while infusing health equity and social justice through that curriculum. She's just been stellar in that effort. I'm always amazed and impressed with what you've done with the Gateway curriculum, infusing that humanism and that engagement. She's lived that life here, being active in our own integrated health network, which, as we know, is really advocating for a network of community health centers and health and community care. And so she's brought that voice there and other places that she'll tell you about. So just real quickly, I have to just share some of her background. She joined us in 2017 after serving as professor of medicine and associate dean for educational strategy at University of Colorado. She was the director of the Academy of Medical Educators, a organization or a unit that she actually established here at Washington University. She had spent 11 years prior at the University of California, San Francisco. She's been active as a member of the Internal Medicine Board of the American Board of Internal Medicine. She's been passionate about mentoring and served as a project and career mentor to over 100 faculty. I'm sure it's a lot higher than now, nationally, internationally, over the course of her career. She's a visionary in medical education, a national leader. She has been brilliant and moving the medical school through a lot of turmoil over the past 3 years as she also shepherded our efforts to combat the pandemic in a safe manner and to engage the community in our efforts to vaccinate in an appropriate manner and share that information. So she has just had a number of hats which she's worn quite well. Dr. Agard.
Thank you, Dr. Ross. I am really so pleased to be here tonight. This is actually one of my favorite events. I have come every year in the 6 years that I've been a part of this community. And it's really important to me because it's an opportunity to meet so many important members of our community, to learn more about our history, and to learn from you and with you, acknowledge some of the many harms of our past and their persistent impact, and to contemplate and sometimes celebrate the ways forward. Before I introduce Dr. Wilson, which is my primary function, I would like to take a moment to talk about one of those ways forward that we've been working on here in the School of Medicine, and Will talked about it a little bit, which is the new curriculum. This curriculum was actually paved, the way forward that I'm going to talk about was actually paved by Dr. Ross and deeply supported by the work of Dr. Wilson and the entire Office of Diversity, Equity, and Inclusion here on campus. Many of you will have heard of WUMP, or the WashU Medical Plunge. How many of you have heard of that before? Some of you. So this was a curriculum that was designed by Dr. Ross and facilitated by Dr. Stevenson and the students for many years that was delivered to all medical students. It provided a week-long immersion into the history of racism in St. Louis and the lasting impacts on health and health inequities. The only criticism of WUMP was that it only occurred in orientation and then never really came back, which said something about the value that we placed on teaching our young physicians about health equity. Alongside this, there was an elective that was developed by the Integrated Health Network that was offered to our WashU students as well as the SLU students that encouraged students to dive a little bit more deeply into the social and structural determinants of health. So in 2020, when we launched the new Gateway curriculum in the medical school, we really tried to build on what we learned from those really important efforts and expand them with the support of the Integrated Health Network and other members of our safety net workforce. Health Equity and Justice is now a longitudinal curriculum that spans all 4 years of the medical school and is led by Caitlin Reedy-Rozier, formerly of the Integrated Health Network and now a full-time faculty member in the School of Medicine, as well as Dr. Radhika Jain, who just joined the faculty and who's newly working, if you're looking for a great doctor, at family care centers. She was a graduate of Washington University in one of my first classes that graduated. So each week in the first 16 months of the curriculum, our students explore issues of racism and inequities in health, with a focus on the social and structural barriers that have led to these health inequities. Students complete required community service work with established partners in the community, and it's really critical that we do it this way, to learn about how we do things in a sustainable way and with community partnership at the core. They also learn trauma-informed history taking and physical exam skills, as well as clinical decision-making. They explore patient experiences of social determinants of health and early clinical experiences that are called immersions, and they reflect on how these experiences will impact their professional identity longitudinally in their subsequent clinical experiences. They continue this work in phases 2 and 3, so instead of 4 years, we divided it up into 3 phases. Phase 2 is the traditional core clerkships that many of you will recognize, where students rotate through, in this case, 6 core clerkships in key specialties. And during this time, each rotation begins with unique training and how the social and structural determinants of health impact the unique diseases and patient populations that they're caring for in that specific rotation. And then they cap off, or during their rotation, all participate again in an aligned community service activity with a community service partner in the community. Each clinical clerkship also incorporates the ability to reflect, throughout the year on patients whose care was impacted by inequities and opportunities that exist at the individual and structural levels to address these inequities. Importantly, we've developed and are continuing to deepen our partnership with our safety net community. Students spend time in their immersions and in their clerkships at KRSTL, Affinia, and family care centers. They work with interprofessional colleagues in those places and throughout to understand the importance of teamwork in addressing social and structural determinants of health and delivering excellence in healthcare. And then in the final phase of the curriculum, which is when they're really differentiating into their specialties, students develop a deeper understanding of how health inequities impact their chosen specialty or a unique area of interest through something called our Keystone Integrated Science courses. Students who want to dive deeper into this and to consider a career path have the opportunity to participate in a longitudinal Career Explorer program in global health and advocacy led by Dr. Daryl Hudson of the Brown School and Kayleen Matar of the School of Medicine. They can pursue a dual degree to receive a master's in public health led by Dr. Ross or public health sciences by Dr. Kolditz. And this year, in collaboration with the Integrated Health Network, we have our first 2 community-based health equity fellows. These students will work in a year-long fellowship with Dr. Jesse Davis and the Integrated Health Network, embedded in community to support critical community-based work. Alongside our combined degrees, this expands our ability to train the future workforce prepared to address the longstanding inequities in our community and in society more widely. This entire curriculum and program is built on this strong foundation of WUMP and would not have been possible without the critical training provided by the Office of Diversity, Equity, and Inclusion and the vision of Dr. Wilson. It also stems from deep support by our community partners, specifically IHN, KRSTL, Affinia, Family Care Centers, and so many others. Our longstanding partnership with IHN, initially under Bethany Johnson-Javoy and now Ndwele Jolly, not only facilitated the creation of the curriculum, but continues to grow, shape, and evolve it. And together, these represent what I consider to be one step forward in addressing the impact of racism and its persistent harms on our community. My deep gratitude goes to everyone who has helped build and sustain these critical efforts. I sometimes say to the students that the reason I got into education is because it's a way to impact a whole bunch of people who can go on to do great good. And I really see that this curriculum is set up in a way to help to do that. And now I get to introduce Dr. Wilson. Cherie Wilson joined the Washington University School of Medicine as the inaugural Associate Vice Chancellor and Associate Dean of Diversity, Equity, and Inclusion in October of 2018, where she was charged with leading the newly established Office of Diversity, Equity, and Inclusion. Under her tenure, a strategic plan for ODEI has been created, a programming and professional development unit established, a 26-member DEI liaisons group has been formed and is active. A diversity advisor toolkit has been developed. A school-wide understanding systemic racism curriculum has been implemented, which is fundamental and core to supporting the learning environment in which our students are going through the curriculum. The School of Medicine received no citations for LCME diversity standards. That's a miracle. In the February 2023 accreditation visit, and most recently, an academic pathways program has been launched. Prior to joining WashU, Dr. Wilson was the Associate Dean for Cultural Affairs and Diversity Initiatives at the University of Iowa's Carver College of Medicine, where she provided leadership, direction, and assessment of diversity and inclusion efforts throughout the College of Medicine. Dr. Wilson has authored or co-authored publications on inequities in medical clerkship grading, the experiences of faculty of color at historically white institutions, and professional leadership development. Dr. Wilson earned her BS degree in speech pathology and audiology from Ball State University and from Indiana University, an MS degree in college student personnel administration and counseling, and a PhD in educational leadership and policy studies. She was a member of the first cohort that completed the 9-month Diversity and Inclusion Certificate Program through the AAMC, which is our oversight body and convening group, and Georgetown University. Dr. Wilson also earned a certificate in emotionally intelligent leadership, which I think speaks to a lot of what she's been able to accomplish here, through Case Western University, Weatherland School of Management. Dr. Wilson is a member of the Association for the Study of Higher Education, the National Association of Diversity Officers in Higher Education, and the National Career Development Association. She is also WashU Medicine's designated institutional representative for the AAMC's Group on Diversity and Inclusion. Please join me in welcoming Dr. Wilson.
Thank you, Dr. Agard. Good evening, everyone. Before I introduce our phenomenal speaker, I want to do two things. First, I want to begin by acknowledging that our university is located on the ancestral lands of the Osage Nation, Missouri, Illinois Confederacy, and many other tribes who were removed unjustly. We are the beneficiaries of that removal, so as we gather here this evening, we honor Native Indigenous, American Indians, and First Nations people. Next, I want to thank Dr. Ross, Dean Lisa Stevenson, Liz Riggs, and Tona Wilson for all the planning and coordinating to make our annual Homer G. Phillips Public Health Lecture Series another success. We can already tell it's going to be. So we are pleased to welcome Brenda Battle as this year's guest speaker. Now, I need you to get comfortable because Ms. Battle has over 38 years experience in healthcare, and I want to make sure I give her her props. So sit back. Brenda is originally from St. Louis. She is one of 11 living siblings and the daughter of the late Bishop Jesse Battle Sr. and Mrs. Mary Battle. She is married to James Sparks and has lived in Chicago for the past 11 years. She joined the University of Chicago Medicine Health System in 2012. She serves as Senior Vice President for Community Health Transformation and Chief Diversity, Equity, and Inclusion Officer. In this role, she designs and oversees University of Chicago Medicine's Community Health Transformation and Equity strategies. She develops and implements coordinated, innovative healthcare, social, and economic solutions to address the social determinants of health and reduce inequities for communities and populations served by University of Chicago Medicine. She is also responsible for crafting strategies and programs to create an environment that promotes diversity, inclusion, and culturally sensitive care delivery models. Before joining University of Chicago Medicine, Brenda was the founding director of the Center for Diversity and Cultural Competence here at Barnes Jewish Hospital. There, she developed and implemented the hospital strategy for diversity, equity, and inclusion and oversaw programs to eliminate health disparities, promote cultural competence, and health literacy. Our office continues to benefit from that founding because we work very closely now with Dr. Stephen Player on similar initiatives. As an industry leader in health equity, Brenda has a successful history of implementing strategies that result in incremental and systemic change toward improving the health and wellness of vulnerable populations. And she has received numerous awards and recognitions of that work, including in 2021, when she was listed as one of the top 25 diversity leaders in healthcare by Modern Healthcare publication. They honor healthcare executives who have demonstrated a commitment to expanding and improving access to care, regardless of a patient's race, ethnicity, gender, or sexual orientation, and to advancing diversity within the industry's leadership ranks. While in St. Louis, Ms. Battle served on several boards and now serves on the board of directors of the Red Cross of Chicago and Northern Illinois, CARA Collective, the Southside Health Community Organization, and America's Essentials Hospitals Institute in Washington, D.C. As a national speaker, she often addresses health equity, reducing health disparities, and systemic racism. Please join me in welcoming Brenda Battle as the guest speaker for the 27th Annual Homer G. Phillips Health Symposium.
Okay, well, it's great to be back home. This is really exciting. I first want to acknowledge you, Dr. Murdock, and just say what an honor it is to be back home to speak during the time when you were being honored. You might not remember this, but I have worked and ran into your office for many years in the past, in my years here, and you were always helpful, so I just want to honor you for all that you've done, and congratulations on your honor tonight. Okay. All right, so I've been given a precise amount of time that I have to get this out, so I'm going to get this out. First of all, I do want to thank Dr. Ross, Lisa Stevenson, and just the group of folks who thought to invite me back to have this talk. I really appreciate it. It actually came as a surprise that I was invited to come back. So when Will sent the message to me and said, would you consider it? It was like, absolutely. I mean, what an honor to come back and talk to my community in St. Louis about what I've been blessed to do in Chicago that really stemmed from what I was able to do here in St. Louis. So thank you for the opportunity to do it. Thank you to all of the folks in the audience that came out tonight and those in the audience. And thank you to my amazing family that also came out and to be with me tonight and to probably pray for me and all the things you need to make sure that this thing goes well. All right, so I left St. Louis about 11 years ago, as has already been spoken, to join the University of Chicago Medicine and to lead the Urban Health Initiative, which had done a lot of work in the community of Chicago to address issues of systemic racism and inequities. But when I joined, it was a real privilege because I got to go really deep in my work to address structural and systemic inequities in the Chicagoland area. And that was a real privilege to be able to do that, because what I want to talk to you tonight is about what that means and what kind of commitment it takes to actually go deep into addressing some of these issues in communities that are highly, highly marginalized, like some of the communities here in St. Louis. So I hope this is an enlightening discussion and a motivating discussion, and I hope that this opportunity to share some insights will be useful to this audience. So my first job is to avoid messing up. So with this, so I'm going to talk about what happens when hospital anchors and communities get lost, because this talk was stemmed from Homer G. Phillips and its amazing work in this community, but that institution was lost. And so what does that mean when an institution like that is lost to a community? So I want to start there. I was asked to talk about that. And then I was asked to talk about what is some of the work that we've done in the community of Chicago, because we've had multiple institutions be lost in Chicago. And so the impact of that, we feel that every day. But before I do that, I really want to pay homage to this incredible institution. You can't really come here and talk at the Homer G. Phillips lecture series and not pay homage to this institution. And you know, I looked out for a number of pictures, and I saw a number of pictures, and some were, you know, black and white, and some were a little dull, but this one, even though it's a little fuzzy, I mean, it's bright and sunshine, and it really depicts what this institution was to this community. So fuzzy or not, it was my favorite picture, so I want to pay homage to it, because had it not been for this institution, we would not have the vast number of Black doctors that took care of so many people in this country, who were trained there at this fully equipped institution, accredited, who did such an amazing job in taking care of so many of us, including me in this room. So have to pay homage to the institution and appreciate what it has done for the world of medicine, and what all of the physicians and nurses and technicians and all of you who contributed to this work have done for the world of medicine. So I want to thank you. And I want to talk about what happens when a hospital closes. Now, I put this timeline together. I'm not that super great with PowerPoints, but I wanted to depict something, and I'm not going to do through every one of these points. You can read it yourself. But I do want to focus on the fact that during the time of Homer G. Phillips, during that era, from the early 1900s until 1979, there were only 3 hospitals that took care of Black folks in St. Louis. You know, some started, some closed, but there were only 3 hospitals. I don't care how you look at the timeline, there were only 3 hospitals that took care of Black folks in St. Louis. And the St. Louis population was steadily growing. It was during the time, early 1900s, of the Great Migration. Folks were coming up from the South to find a place to have, to build family wealth, to have opportunity, and the city only had 3 hospitals to take care of them. And most of them weren't well-equipped hospitals, and the facility structures weren't actually that great. And then when Homer G. Phillips, finally, when the bond was passed and it finally got bid, this was a big hospital. It was 685 beds. Now, for those of us who work in healthcare, we know that if you get a hospital that's 685 beds, that is incredible. That's an incredible size. That's like half the size of Barnes-Jewish Hospital. That's like a big hospital that provided all the services to take care of folks. It was amazing. It provided primary care and specialty care and maternal child health and all of the necessary services to take care of individuals and the population in the St. Louis area. But it never got supported. It never was invested. It was never invested in. I don't know if you know this, and obviously I did my study. I didn't even know this as long as I lived in St. Louis, that it was funded by donors. It was supported by city funding. It was supported by Washington University and St. Louis University, so I want to thank them for that. But it was hard for an institution that big to survive off of that kind of funding to support it. And so by the time the Medicare and Medicaid Act was passed, Medicare is health coverage for the elderly, Medicaid is health coverage for the poor, it was too late for Homer G. Phillips, to be honest with you, because it had been underinvested in for so long that it had no way of surviving, even though there were these opportunities to be funded through these other mechanisms. But the other thing that happened is what we see today when managed care comes into our communities, is that people who had the ability to go other places for healthcare services, they actually went. So Homer G. Phillips closed because it was never properly invested in, and then when Medicare and Medicaid passed, where they could get funded through state and federal funds, there was an out-migration of folks to some of the other institutions that had historically cared for Black people in the St. Louis area. So here's what happens, and I'm going to run through this, and then we're going to get down to the other half of this discussion. So what happens when hospitals are underinvested in is underinvestment and declining volumes, it depletes the revenue of the hospitals. And these hospitals are safety nets in the communities, and if you deplete the revenues of the hospitals, it's hard to sustain the hospital. Because depletion of revenue results in the lack of funding for clinical care, the lack of funding to hire providers, to have programs, and what happens is the quality of care gets compromised at hospitals. And then that lack of revenue, lack of quality, leads to program closures, ultimately hospital closures, and then problems with access to health care, both to hospital care, to care from providers who could take care of patients, all of that, it's like a trickle effect that happens. But then what happens to the neighborhoods? I'm going to go through this. I don't expect you to read that. So first of all, hospitals are anchors to the communities. They provide jobs, and what I hear from the community in Chicago is that the thing that people are most afraid of when hospitals start closing is the lack of jobs, is that people are going to lose their jobs. Because a lot of people who work at those hospitals live in the community, so that's what they fear the most. And so they're anchors financially, but they're also anchors professionally. And they're a source of pride for communities. So when communities start sensing a decline in the institutions, communities get afraid, basically, and it creates fragility in these communities. So these are some of the things that happens. It's like a trickle-down effect. They don't all happen in the same order. They don't all happen in all of the communities. But we need to note that some of the things that we see in communities are a result of losing anchors in these communities. So first of all, they lose access to health care. Hospital care, emergency room care, primary care, specialty care. Then supporting businesses that support hospitals like pharmacies, dental offices, grocery stores where people get supplies, sometimes medicines too, you lose those because they can't sustain. And then other employers in those communities, and think about this if you were here during the time of Homer G. Phillips, those employers can't sustain either because the revenue that would come from people using those businesses, they can no longer use those businesses with a steady pace, and so those businesses are lost. And when you lose employers in communities, it's hard to bring new employers into communities. The obvious is the healthcare, the result on healthcare and disparities. But the other thing that happens is you lose home sales. The value of homes go down. And so then you lose the tax revenue from those sales that supports schools and other public infrastructure. So we see a degradation of schools in the communities. And lastly, you start seeing the social instability, increases in violence, housing insecurity, food insecurity, name it. That's what you start seeing when hospital anchors close in communities. And here's the equation. Basically, underinvestment, the lack of access challenges, we just talked about this, centers around this underinvestment, primary care deserts, inaccessible specialists, plus unmet social needs, unemployment, housing insecurity, food insecurity. You're going to have poor health outcomes. There is no other option. Now, these are St. Louis data. I'm going to show you some Chicago data. It's worse than this, but it's St. Louis data. That's what you get when hospitals close. So we're going to move on to the next part of this discussion, because what we're doing in Chicago has very much to do with the fact that we've lost so much healthcare infrastructure in Chicago. And so realizing that, we realize that we have got to take some pretty darn drastic moves to try to change some of the realities that are occurring in the communities in Chicago. And when I talk about Chicago, because I've been asked to talk about Chicago, if I were here in St. Louis, I could say the same thing about St. Louis, but I'm going to talk about my work in Chicago. But I think it's first to start with understanding that solutions to address health disparities are not necessarily healthcare solutions, and they're not mostly healthcare solutions, because about 80% of what helps people to have good health care have nothing to do with medicine and genetics. It has to do with the structural determinants of health. And so if you're going to address them, and I'm glad we are training students to do this, if you're going to address them, you've got to address the structural issues of inequities and the structural issues of disparities. And so that's what we're trying to do in Chicago, is to look at these issues of disparities, what has happened in our community from that perspective. Before I get into some of the details around some of the things that we're doing, I want to talk a little bit about the Chicago community. I'm assuming some folks in this audience have been to Chicago. Mostly when I used to go to Chicago, I used to go to the cool side of Chicago. I didn't really go to the side of Chicago that I work in now. And since I've been there, I understand a heck of a lot more about Chicago than I did as a visitor to Chicago. So here's some realities about it. First of all, it's big. The south side of Chicago there are 900,000 people who live on the south side of Chicago. That's as big as most cities in the United States. And if it were a city, it'd be the 18th largest city in Chicago, or in the United States. It's big, 900,000 folks. But over time, the South Side has lost numerous healthcare resources. Over the last 25 years, we've lost 10 hospitals, and the most recent loss was in 2021. 30% of the residents live at or below the poverty level. Interestingly, the high school graduation rate is 85%, but the unemployment rate is 15%. The average unemployment rate is one of the highest in the country. It's 15%, with some communities being as high as 35%. And for our ED care in the south side of Chicago, 60% of the ED care is for primary care preventable conditions because of the dearth in access to care. So our framework for addressing these issues fall within 3 buckets. One starts with authentic community engagement. That is the key to how you move from where you are to where you end up, is engaging the community. So I'm going to talk a bit about what authentic community engagement actually means. And then one of the main structural barriers to health outcomes is economic. It's jobs, access to jobs, but well-paying jobs, living wage or better jobs. That's key, and so that's one of the areas that we're working on. And then third one is around enhancing the health of the local community, and we'll talk about some ways in which we're thinking about that. So our methods include both incremental and systemic approaches, because we know that you just don't get to systemic outcomes. You don't get to systemic solutions. The pathway there is incremental. So we're looking at what can we do incrementally to get to long-term solutions. And our main focus is on reducing poverty as the main social driver of health disparities. So I do want to say, as much as healthcare has contributed to health disparities, we didn't create them all. So we can't fix them all by ourselves. So our approach includes investing in these solutions ourselves, but also participating in collective efforts with corporate and philanthropic and government partners working alongside the community to develop and execute strategies that will have long-standing effect. So let's start with authentic community engagement. So there's a pastor in Chicago who reminded me when I first got there, because they didn't trust the University of Chicago, because the University of Chicago was not a good partner for a very long time to that community. And so he made a point of saying to me, don't even think about it. You're new to this city, but you can't do anything for us without us. I was like, here, you got it. I'm with you. So when we think about authentic community engagement, we're talking about really centering these efforts around the community. How do we involve the community in the solutions? Because the community knows what's happening. They know what's impacting them. They know what you need to do to fix it. And so if you're going to address issues and have solutions for communities, you really, really do have to engage them in those solutions. But we as academic institutions are often guilty of solutioning because we're so smart on behalf of the community rather than allowing the community to help build those solutions that will be more long-standing. So that's key. And so we leverage our community advisory councils. We do listening sessions. We let them direct us into the listening sessions so that we can hear what the community is saying to us. And then we have taken that and shown to the community the results of what they ask us to do. Because you can center around the community, you can authentically engage the community, but if they don't see that what they said they need, you're actually doing it, that means nothing. All you're doing is wasting their time and having conversations with them, and they're sick of our conversations if our conversations don't turn into something. So authentically engaging the community is doing something about what it is that they told you that they need and using the solutions that they've given you to actualize. So that's authentic community engagement. The next area of employment and workforce is really key. This is a place where we made the decision that while philanthropy is great, and yes, we're going to rely on philanthropy, but as a corporate structure, as a corporate entity, we have greater ability to actually influence longer-standing change because we're a business in the community that we operate in. And there are other businesses in the communities that we operate in. So if we came together as businesses and agreed that we would commit to hiring from our community, commit to promoting from within, commit to investing in our communities, other corporations committing to bring their businesses into the South Side, like Discover Card and AT&T and Blue Cross and Blue Shield and Felco, a number of employers that have brought their businesses into the South Side of Chicago as a result of this collective approach to say, hey, we have got to commit to making sure that we recreate jobs in this community and that they are living wage jobs where people can take care of their families and they don't have to be on Medicaid and they don't have to be on welfare, that they can truly take care of their families and they get health insurance. This is what this strategy is about, being real about that, thinking about how we spend our money, who we spend our money on. Those things are real. And so this is a part of this engagement. Our average pay for our employees is $31.50. We don't pay anybody under $18. The most entry-level person in our organization doesn't make less than $18 an hour. That's a real commitment to make sure that we are authentically responding to this need of closing the wealth gap. We also, under buying locally, we have committed 41% of our construction being spent on minority and women-owned businesses. And we are standing up right now an $815 million cancer pavilion. No less than 41% of those dollars will be spent on minority and women-owned business. It's really putting your money where your mouth is. If you're not gonna put your money where your mouth is, you're wasting the community's time and you're not addressing these systemic issues that create poverty in communities and create lasting disparities in communities like our community. So, I gotta drink water because I start talking really, really fast when I get excited. And yesterday I talked to I have this executive coach and she's like, you need to slow down. And I'm like, I don't know how. Anyway, so this last one is enhancing the health of the local community. And so when we think about health, we don't think about just medical health, we think about broad health and wellness. And so as hospital institutions, not-for-profit hospital institutions, one of our requirements is that we conduct community health needs assessments, which means we go out into the community, we ask the community what the issues are, we take that information, we pair it against secondary data, and then we're supposed to work with the community to prioritize those health needs and then execute our strategies based on that. Most hospitals don't go back to the community to prioritize their needs, they prioritize themselves. We don't. We actually have prioritized our health needs with the community. So this first slide is one of the questions in our needs assessment that asks the community, what do you think are what's important to a healthy community? And so these first 6 things are things that they said to us: safety and low crime, access to healthcare and mental health services, you can read them, access to community services, healthy foods, housing, and quality jobs. So undergirding all of our work are these efforts, these interventions around food security, housing security, but these big things that we knew that we could make a difference on, like jobs and healthcare, access to healthcare, and crime and violence. Hospitals have not been focused on what they can do around reducing violence. Those are the things that our community said, you can actually do something about that, and that's what we want you to do something about. So the other thing we did is we took the secondary data from the public health data and said, okay, the community said these are the issues. So how do we look at the data and correlate these data points to understand what's really happening in the communities? And what these heat maps show you is that communities with the highest rates of poverty also have the highest rates of violence, and they have the lowest job participation. So when the community says, we want to address crime and violence, and we want to address joblessness, these data inform exactly what the community said, which says to us that the community knows what they're talking about. Don't question the community. They told us what they needed, what makes the community healthy without data, secondary data. The secondary data validated what the community said they needed, and so it's that combination of data that we use alongside the community to decide what we're going to work on. And then the healthcare data, so I think you saw your data that you have an 18-year life expectancy rate between communities that are marginalized. We have the largest life expectancy rate in the country between Inglewood, that dark red hot spot on the last map, heat map you saw. That's Inglewood. We have a 30-year life expectancy rate between Inglewood and Streeterville. Anybody know where the Navy Pier is? That's Streeterville. There's a 30-year life expectancy rate between those two communities. That's the worst life expectancy rate in the community. It also is where we have 10 times infant deaths, and we have the highest rates of diabetes, and you just name it. You can take that heat map, and you can put every chronic disease and violence and sense of lack of belonging, put it all together, and it's the same communities. And so these are the things that we determined we actually had to work on. So we're going to first start with the safety and violence ones, because the community said we got to address this issue of safety and violence in hospitals. I know you think you have no place in that space, but you're dead wrong. You have a place in that space, because by the time a person gets to your hospital, they already need some help with avoiding being re-injured. So don't tell us you don't have a place in that space. So we did a 2.5-day retreat with community members at the most grassroots level to the highest level of civic position in Chicago and said, all right, well then let's talk about what is our responsibility in the space of crime and violence. What is our role? What are we supposed to do? How do we do this? And they laid it out to us and told us what we're supposed to do. Because we don't intervene without co-designing them with the community. That's another way that you authentically engage the community. You've got to co-design your interventions with them. You've got to have them at the table because they know what they need and they know what's missing. They know what the gaps are, and they know what we have the capabilities of bringing to this solutioning. So what we came up with was the first hospital-based violence intervention in all of Chicago. And this was, how do we as a hospital, when a person comes into our emergency rooms and trauma centers, began the effort around reducing re-injury rates? How do we start engaging them in that golden hour? Because violence is a public health issue. And so we have to treat it as a public health issue. And we have to start our efforts to intervene around that at the beginning. So we started with 2 of my team members who had another job, and we moved them over into the hospital to do that. And ultimately, we built this program to a $30 million program. It's about $3.5 million a year. And we have successfully been able to reduce trauma recidivism or the re-injury rates through this program. And we do it through having a group of violence interventionists in the hospitals, but what's key to that is working with the community interventionists around how do we, when a person enters our trauma center, begin addressing the issues of violence, delivering psychological first aid, convincing them to engage in case management, and then working with the street operators to first mitigate the possibility of retaliation, either somebody retaliating against them, or a family member, or them going back out and retaliating against them, leveraging the community-based providers, community-based behavioral health providers, and not just your psychologist or psychiatrist sitting in the office, but the people that are out there doing restorative justice at a church, in a basement, at a grassroots level. These are the partners that we work with, and we've had tremendous success with this program in reducing the re-injury rate. Now, 45% of people who are injured through community violence, as gunshot wounds, stabbings, or assault, are re-injured within 5 years. So this first set of data is through the end of 5 years, through the end of 2022, we engaged 7,300 plus people in our hospital-based violence intervention, and we had a re-injury rate of 2.1%. Because we wrapped these folks around an intervention that they used and worked, and we worked alongside the community in doing this, and we have people still in our program. So this has been a successful intervention that was derived out of the ask of the community. And then the last one I'm going to talk about is an approach that we had to addressing the chronic diseases in our community. So it's impossible to talk about everything that we do, but these are some high-level programs that I did want to share that we can engage in and we can do as academic institutions and healthcare institutions around addressing these issues. So I talked to you about what our healthcare situation looks like on the south side of Chicago. And so we were fortunate that our Department of Medicaid, the Illinois Department of Health and Family Services, issued an RFP for communities that had high rates of disparity, or health inequities and disparities, to apply for an award to address a collaborative approach, to create a collaborative approach to how do you reduce disparities in chronic diseases and social determinants of health. And so we led this work on the south side of Chicago. We pulled together all of the healthcare providers, the safety net hospitals, the other large healthcare institution, and the federally qualified health centers. And we put together a proposal, and starting with the community, because we engaged the community first around what's a healthy community look like. And the community were like, look, first of all, we're tired of going to the ED to get primary care because we can't get primary care. There's 150 fewer primary care on the south side of Chicago than we have. There's 75 fewer specialty care providers than we have. The community said, look, we have no way of navigating the healthcare systems. You know, we don't know how to access some of these resources that you guys are already talking about. And so we put together a proposal, which is online, you can get it, easy to get it, it's open to the public. And we were awarded $146 million over 5 years to do this work. So, here is the work. our model is focused on, we stood up a not-for-profit organization called the Southside Healthy Community Organization. The model that we developed has 4 major components. It's increasing primary care access, increasing specialty care access, and collectively working on chronic disease management and behavioral health support. It's developing a team of care coordinators, primarily community health workers, nurses, and social workers, working in all of our sites, all 13 of the partner sites, to connect and help patients navigate to care and get access to care. And then it's leveraging and connecting our IT, our electronic medical records, together. So the University of Chicago lent its Epic, its instance of Epic. Epic is our EMR, and we created a portal that doesn't mix data because that's against HIPAA rules, to allow the entire South Side to get access to Epic, to be able to enable us to better coordinate care in this new system of care. It's an integrated care delivery model that we've executed, and this is what it looks like for the patient. I mean, in the old model status quo, a patient would come to the ED, they might get screened for social determinants of health, they get care, they go home. In this new model of care, you have community health workers meeting patients at every ED on the south side of Chicago. And then you have community health workers at the federally qualified health centers and nurse care managers at the federally qualified health centers. So when that patient enters our ED, they encounter that community health worker who starts that social determinants of health screening and starts that linkage back out to the primary medical home immediately. And then because we now share an electronic medical record, that data is then transmitted to the primary medical home, and then the care that that patient gets when they get in that primary medical home continues to be linked. We've reduced losing people to care by over 50%, and we've reduced no-show visits at the primary care down to by 68%. So it's been a very successful model for getting people into care. And then the other thing that we know, because we have now linked electronic medical records, is we know what are the main reasons people are coming to the ED, anybody's ED on the south side of Chicago. And it's behavioral health, hypertension, and diabetes. They're coming in for the other reasons, but what we know is no matter what emergency room the persons are coming into for care, most of them have behavioral health problems, they have hypertension problems, or they have diabetes. We would have never known that unless we linked our data through the electronic medical record, and now we're able to do that. So now we're able to intervene around what we need to intervene around. So this is my last slide, and I'm almost out of breath, but I'm trying to make my time. Okay, so this point is this. None of these circumstances happen independent of each other. That interventions have to consider the intersectionality of all these issues. So you saw in our heat maps that the communities with the highest rate of chronic disease and highest rate of violence and highest rate of those things don't sit alone. Chronic disease doesn't sit alone. So if we're going to intervene, we've got to figure out, and we haven't gotten there yet, how to create interventions that have all the intersecting components in them so we can solve everything at the same time or together, rather than trying to solve for social determinants over here and then trying to solve for chronic diseases over here and then trying to solve for issues of violence and post-traumatic stress. We're trying to figure out with our community how to do it all at the same time. So if you invite me back in 10 more years, because I'll be retired by then, we will have figured that out. So the point of this is this. I believe that if we work together to do this, if academic medical centers and hospitals and corporations and philanthropy and government work together, that we could change the situation in the communities that we have. And if we authentically engage the community in doing this, we can make some incredible changes. And then we can become models for the rest of the country and the rest of the world around how we do this. So my request of you is to do that. It's not easy. Nobody said it was easy, but if it was easy, somebody would have done it already. And so that's the end of my talk. I thank you so much for this opportunity to come back and talk to you. This has been such a blessing. Thank you so much.
Stay here. In 2006, I was meeting with Andy Ziskin, the president of Barnes Jewish Hospital, And we were talking about what we can do to advance cultural diversity. And I said, we need to create a Center for Cultural Diversity. He says, great idea, Will. Who do you want? I said, I have a person. She'll be great. Her name is Brenda Battle. So I went to Brenda Battle, and she said no. She didn't want the position.
Bugged me to death. I said no for 6 months.
I said, this is a person, and you can see why we wanted Brenda Battle here. And she transformed this institution while she was here. You can see the remarkable change in Chicago. Still an uphill battle all over, but this is a type of personality that you need to really drive systemic change.
Thank you.
And so on behalf of Washington University School of Medicine and our dean, David Perlmutter, I'm pleased to present this plaque to you. It states, this award of merit is presented to Brenda Battle, RN, BSN, MBA, in recognition of your commitment to social justice, health equity, and transforming healthcare delivery. Given the 6th day of October 2023, Washington University School of Medicine, David Perlmutter, Executive Vice Chancellor for Medical Affairs, and Will Ross. Congratulations.
Thank you, Will. Honestly, if it wasn't for Will pushing me to do that, I would not be doing what I'm doing today. And this is the work that I was intended to do. So thank you so much. Oh, yes, sir. Okay. Gotta get Judy. Thank you. Thanks, Will.
Absolutely. And so, wow, what a breathtaking presentation. Isn't she full of energy? That's how you get change. You put people who really believe in it, who have that spirit, who can convince others of that need for systemic change. Brenda Battle is just a remarkable person. Now, let's talk about another remarkable person, Dr. Nathaniel Murdock, Jr. I've known Dr. Murdock, my goodness, since I started my fellowship here in 1987. He was the sort of person who was just approachable, easily approachable. When we needed him to come and speak to our medical students, he said, no problems. When we needed him to be on the forefront of Congress to affect national policy, he said, no change, no problem. When we needed him to take care of women in this community, to address the myriad ills, unfortunately, that affect the African American females, and not just in St. Louis, but throughout the country, because of the high rates of disparities and unfortunate high maternal mortality and subsequent infant mortality. He said, no problem. So that's why we chose Dr. Nathaniel Murdock as an honoree for the Honoree G. Phillips lecture. He's just a remarkable person who says, no problem, I can take care of that. You have his bio in the insert. I just want to highlight a few lines of that bio. It's quite impressive. He has over 50 years of experience in the medical field. He's given himself unselfishly, as I stated. We were pleased that he's been a part of our community here at Washington University. He was on faculty here for 45 years. He has been in positions of leadership with the National Medical Associations, having served as president. Here locally, he was president of our affiliate chapter, the Mountain City Medical Forum. He served as president of the St. Louis Metropolitan Medical Society. In his position as president of the National Medical Association, he spent considerable time testifying before Congress, advocating for those policies that Ms. Battle just spoke of. He was awarded the Robert Schuller Leadership Award by the St. Louis Metropolitan Medical Society based on their very specific criterion of leadership, scientific attitude, advocacy, and community service, and for his long-standing contribution to medicine that is above and beyond the norm. He has an extensive network here in St. Louis, engaging nonprofits, using his expertise to bring people together, to promote advocacy, to promote leadership in the philanthropic sector. He's done just a yeoman's job, and he's done so because he has at his side Sandra Murdock. Let's give her a hand. She really is the wind beneath the sails. Sandra and Dr. Murdock served as chairs of the 2005 United Way's Charmaine Chapman Society, and we certainly know that that's been kind of a national leader. St. Louis has been a national leader in raising funds for the United Way, starting with that society many years ago. He's a life member of the Urban League and the NAACP and received so many awards. Dr. Murdock, we would be here another half hour if I talked about all the awards. He actually obtained a bachelor's degree in chemistry in 1958 from Howard, then a medical degree in 1968 from Harry. He completed some training here at home at Phillips Hospital, then went 2 years to the Air Force attained the rank of captain. He then joined our faculty at Washington University in 1969, and he is, as they say, the rest is history. So, Dr. Murdock, we're just thankful that you're here. We really applaud your service, your commitment, the decades of service to the women of St. Louis. They're healthier as a consequence, and we're healthier as a community. Thank you, Dr. Murdock. Just a second. Stay right there. We have an award for Dr. Murdock. It reads, this award of merit is presented to Nathaniel Murdock, it should say Jr., MD. It doesn't say Junior, but it should. In recognition of your untiring efforts to improve women's health and for national leadership promoting health equity, given this 6th day of October 2023, Washington University School of Medicine, David Perlmutter, Dean, Will Ross, Associate Dean for Diversity. Congratulations. We have to have a Judy Bentley take her picture.
It's official now.
Oh, yes. Dr. Murdock.
Thank you very much. Hello, you should know my name by now. I am Dr. Nathaniel Murdock. I practice obstetrics and gynecology in the St. Louis area for over 60 years, and I'm only 85 years old. I want to acknowledge my superb training as a resident at Homer G. Phillips Hospital. The opportunities afforded me many opportunities and physician contact there were life-changing occasions. My dedication to service started at Homer G. Phillips Hospital. It was an initial landing place for most African American interns and residents. We were fortunate to have such an outstanding institution at a time when few places would accept us. We made do with what we had and preserved. Homer Phillips Hospital, a 455-bed unit, provided training in specialization, choices, variety, and quality medicine. My time at Homer Phillips helped me grow in wisdom and knowledge, and I also was afforded the expertise to have a vibrant and economically sound practice. Medicine is a rigorous field. Medicine is a joyous field. The promise of medicine is a career where education and ambition may marry and allow you to serve. In summary, I specialized in obstetrics and gynecology because I wanted to be the best in bringing life into the world. I knew that diving into such a specialty meant that I could serve my community as an expert in the valuable area of medicine. I guess I should have said in this area of medicine, women's health. I invite you to specialize in medicine or your chosen career. Align yourself to serve the community and be a part of the greater good of society. I must acknowledge and heartily thank Washington University School of Medicine. I thank you for the honor tonight and for allowing me to serve on your faculty. I thank my family and friends for attending this event. I am most grateful for you allowing me to share my story and once again serve the St. Louis community. This is a community that I've always loved and always will love. I thank you for all of the things you've done for me, given me, and the infinite times I've spent in Homer Phillips Hospital and other hospitals like that. I hope always to give credence and good work to this profession. Thank you.
I want to thank you all for joining us on this special day. We've been inspired, Ms. Battle. We've been inspired, Dr. Murdock. We recognize what we need to do, and we're not going to be told that it can't be done. So thank you for that message, and thank you for that leadership. I want to thank our virtual audience. I know you're there, and I know that you're listening just as aptly to this presentation as our in-person audience. Thank you for joining in online. I know I will see you all in the future at these and other forums. I hope that you will continue to embrace what we do in the Office of Diversity, Equity, and Inclusion at Washington University, and how we're always fostering this type of community engagement and community good. Thank you so much. Have a good night.